of this particular program to address your information issues. Now, there were a couple of comments made about the specialist mentality about doctors. And I look across this room and I find that there are very, very few who aren't actually specialists, including the two gentlemen who just walked in from the Heart Center. So I guess the question I would actually throw out here is it time that we revise also the medical curriculum of all universities, not just of the Ateneo, but every single university should now focus on developing or producing primary care physicians rather than specialists. Let's face it, when you invite the best and the brightest minds, of course they'll want to go abroad. Of course they'll want the highest technology. But you have to start really revamping the kind of orientation of the supply chain, I guess, of your key talent for the future. Right now, the key talent in the pipeline for the medical curriculum, or at least on the doctor side, the medical side, we've talked about infrastructure, we've talked about nurses, let's talk about the medical side. If you talk about the medical side, almost every single graduate, I bet you, wants to be some kind of a specialist. But I only find out now that I'm not really a full-time practitioner anymore, that you really need to start integrating a lot of the needs of the individual patient who comes to you. So it's really about time that I think we really revisited our medical curriculum and refocus what is the direction, how can we create generalists rather than panay specialists.
Yeah, Peter, can I just mention something about the out-of-pocket? It's a little deceiving, that number. That how much is out-of-pocket? Was it say 57? But that's considering both the private patients and the NHDS. Now, a study recently done by UP Manila showed that for the NHDS, for the poorest patients, their out-of-pocket is only like 13% compared to poor patients who do not have PhilHealth. The huge out-of-pocket, they did not segregate it, is from the rich patients, and that 80% out-of-pocket is mostly for medicines which are supplements, not essential medicines. So, not even essential medicines. They are supplements, they are things that are not even life-saving. That's what we did not see in the data presented. So it's a little skewed and a little deceiving. So it sort of does not do justice to the NPD program of PhilHealth for the poor. Okay? But, yeah, and aside from that, maybe it's not just change the curriculum, maybe we just have to really integrate the gatekeepers among the family medicine. Maybe Dr. Duque, Pinkoy muna.
Thank you very much, Mingita. Going back to the OOP, or the out-of-pocket payments. It's one of the issues that continues to be bedeviled on us. Year in and year out, we keep discussing endlessly, interminably, about these out-of-pocket payments. And I agree completely with some of the remarks of Dr. Cabral when she said one of the weaknesses confronting the health system is really old data, belated, data. We talk about the national health accounts data that is probably 3 years old and will not reflect, the massive, an example, a massive benefit payments or payouts of PhilHealth, now reaching or approaching almost 90 billion pesos a week. So, what I'm trying to say is we really need to do something, and I think this is within the powers and influence of the Department of Health, to really come up, ano ba talaga yung data natin? How can we immediately generate this data? Otherwise, we are misguided, we are not able to plan properly, and I think it's going to have very adverse effects in the way we would like to do medium-term and long-term planning for the health sector.
Thank you, Pinkoy. Before I call on Lord Avanson, I'd just like to say that I'm going to do the synthesis, but rather than just rehash everything which has been presented this morning, this afternoon, I have been requested to present the joint planning, some things about the joint strategic planning of DOH and PhilHealth, the first ever. And one of the things we are actually addressing is this problem of data. Because PhilHealth now has an enterprise architecture and we can get data real time. We have a dashboard now, which, of course, these are things people don't know yet and which I would like to share in a very short 10-minute talk, which I will summate, plus really later on, instead of just rehashing, I will just have to say this as part of the main presentation. So please, we need to discuss this so you'll also know what's really happening now. Not 2 years ago, not last year, but now and in the future. This is like a gift for the next administration. So Dodo Banson, you would like to say something? After Dodo, Camilo Roa.
In response to the question that was asked by Secretary Karim, and I think in reflection also of the theme here is moving forward. And both based on the presentations of Ernie and Secretary, I think one of the things to move forward and what was being shown exactly is that when DOH starts realizing what its role is, and the role of LGUs and of PhilHealth, things move forward. And the biggest problem we had for the past few years is that the role was confused. DOH still thinks it's service delivery, and so since it's one service delivery, it wants to do trainings. Because the service provider thinks of training. We want to build your capacity. If DOH, and it's not started to do that, now controlling 112 billion, and start looking, in a sense, really recognize also it's an enabler. So when you say, can we get data captured? Why don't we enable it? A national health ID would simplify the process, requiring all drugs to be barcoded so it can be captured by a simple barcode, like SNP can facilitate things. Having a national health data dictionary with all the diagnoses will simplify things. Purchasing. You control 112 billion, PhilHealth controls probably 100 billion. Combine that purchasing power, and you could just imagine how you could actually make our friends, the private sector, really behave. To be nice about it, it will allow you to harness the private sector the way you harness ZFF. I look at the ZFF process as an outsourcing. DOH is not good in engaging LGUs. They paid ZFF to do it. It delivered. So why don't you give all the money that is given to BLHD to ZFF, and they could probably make all the provinces work. If we look at, and Gap is still here, when I talk about human resources, this is the job of DOH to put people on the ground, or is it their job to make sure there's a ready supply of specialists and consultants in the future? The strength of PGH, and of course Miguel was my teacher, is that I'm 6 batches behind you. The strength of PGH is the residency program. DOH controls about 40 hospitals that is as good as PGH. Imagine 3,000, 4,000 plantilla positions, these are not career positions, basically churning out 1,000 specialists, including primary care positions every day. So DOH's job, just like the way the Japanese Ministry of Health does its job, just like the Americans do it by paying more to Medicare, is instead of thinking that this is my job to put the doctors, their job is to make sure that we have a stream of residency programs, specialists. We will keep on producing the specialists, and the system will be the one to absorb them. So if DOH starts thinking to be an enabler, then things will get done. But of course, to be an enabler, you should also have the power to sanction. And I think this is where DOH is sort of not, I think, because it doesn't have the power to regulate or the desire to regulate. I think at the end of the day, because the accountability was never established. What is the accountability of LGUs that was never established? If the LGUs mess up, what do you hold them accountable to? There was never any performance metrics or contracts or measures. What is the accountability of the private sector? Never established. And so if DOH become an enabler and somebody who insists on accountability, things would naturally happen. And since this is the Philippines, where we really don't like to make plans, we're not good at that. Right? We rather sort of waffle around and then just do great things, you know. So I think that if we start looking at things, and I think as a final word, as somebody working now for a development partner, there are actually lots of countries that use this approach in getting things done.
Okay.
DOH has so much money. There's so many young people here in the country right now with the skill set to do contracting, purchasing, knowing markets, doing research. You have the money to invest. You worry about data. The family health survey, I mean, our friend, I think, Bertie is here. How much? 50 million pesos. You could actually do a family health